we will continue because we have busy agenda, and as it has been already tradition to review cases from the previous year, I would like to invite Luca Kraba from ICEM to give us some overview of cases done in ICEM last year, together with Vasileos Belos. They both will share because there was number of cases, so but brief, okay?
Good morning. Good morning. Let's start with the first case. This is a CT-guided tachycardia ablation of ventricular tachycardia. It's a 73 years old patient with a lot of comorbidities, fragile patient with a previous inferior wall myocardial infarction, with ICD in primary prevention. Here you can see how impaired was the ventricular function. In the memory of ICD, we saw the recordings of a lot of VTs, mostly terminated by ATP. During the procedure, we had the spontaneous occurrence of different morphology VTs, monomorphic VTs. So here you can see the 3D reconstruction of CT-acquired images merged with the carto anatomical map. You can see the scar islets with the channels in between. And these white dot lines are the suggested line of ablation. And this is this was the strategy we followed. So the patient was discharged 1 day after the procedure without apparent complications, but after 1 week he passed away. We didn't have a report by the family. For example, we don't know if the patient had shocks, but likely he passed away because of deterioration of heart failure, because we know that this patient was very, very sick. Second case is a cardio-neuroablation in a patient with a recurrent syncope with likely vasovagal mechanism, with unremarkable ECG and echo without comorbidities, with a positive tilt test for cardio-inhibitory syncope, with an effective conservative treatment. We repeated the tilt test just before the ablation. Here you can see a cardio-inhibitory syncope with a very long sinus arrest. Atropine test. During the atropine test, there was a significant increase in heart rate. Here you can see our strategy that was anatomical guided ablation of ganglionated plexi of sinus node and AV node. The endpoint was the suppression of vagal response to bilateral vagal stimulation, external stimulation. In this case, the follow-up was pretty good. The patient was asymptomatic without pauses in the Holter ECG, and the tilt test was negative for bradycardia or pauses, but it was positive for vasodepressor syncope, but it wasn't. So next case is an ablation of persistent atrial fibrillation using a FARA system. This was a patient with arterial hypertension and severely dilated the left atrium with propafenone as an antiarrhythmic drug. Here you can see the green dots are the pulse field ablation, pulse field application, point by point. Here you can see the isolation of both right and left pulmonary veins and the box isolation. During the procedure, we induced atrial flutter, which was terminated by this line, this ablation line with radio frequencies in the CTI. So during the blanking period, we had a recurrence of atypical flutter, which necessitated electrical cardioversion, and after 6 months, We repeated the Holter ECG, which showed a short asymptomatic paroxysms of AFib. The patient was without antiarrhythmic drugs. So my last case is AFib ablation using very high power short duration RF. This was a patient with arterial hypertension and dyslipidemia and obesity, 65 years old with propafenone therapy, with dilation of left atrium. Here in this case, you can see in carton images the first pass isolation of ipsilateral pulmonary veins. And during the follow-up, we didn't have recurrence, and the patient was without antiarrhythmic drugs. So thank you for attention. Now my colleague will continue.
Good morning, dear colleagues. I will go on with the next cases from EChem. First case is catheter ablation of persistent atrial fibrillation using pulse field. The patient was a female patient with many comorbidities and previous embolic events, high Judge-Vas score, impaired LV function and dilated left atrium on amiodaron. PVI was performed using Farapulse plus ablation of posterior wall and roof. But during procedure, also an atrial tachycardia occurred from anterior wall, which was also ablated. On follow-up, the patient was on durable sinus rhythm at 1 year, and amiodaron stopped on the last visit. Second case is catheter ablation of VT using decrementing evoked potentials mapping. The patient was a 71-year-old male with ischemic cardiomyopathy, previous CRTD implantation, VT storm before some years treated with RF ablation in another hospital. He was in amiodaron, but recently he had multiple episodes of fast monomorphic VT terminated by ATP and SOX. Here we see the decrementing evoked potentials, which are obvious after the extra stimuli from right ventricle. During procedure, a sustained monomorphic VT was induced with exit on the inferoseptal part of left ventricle, which was terminated after ablation of the area, and at the end there was no inducibility of any arrhythmia. Here we can see the propagation map during VT and the mid-diastolic potentials. We can also notice the differences between classic voltage map and decrementing evoked potentials map. During follow-up, there were no VT recurrences at 1 year without taking any amiodaron. Next case is ablation of paroxysmal atrial fibrillation using diamond temp catheter. A 42-year-old female without any significant history, with episodes of paroxysmal atrial fibrillation, normal echocardiography on propafenone and beta blocker. PVI was performed using NSIDE system and diamond temp catheter. And on follow-up, there were no atrial fibrillation or atrial tachycardia recurrences at 1 year without taking any antiarrhythmic drugs. Last case is a bipolar ablation of LV summit PVCs using OZIPCA system. Patient with high burden of PVCs at Holter ECG up to 40% and with PVC-induced cardiomyopathy. She also had the previous conventional ablation of PVCs in EChem at RVOT, CS, RCC and LVOT with only transient effect. ECG on admission shows the high burden of these PVCs. Bipolar ablation was performed using an active catheter on right coronary cusp and the ground catheter backhand on pulmonary artery. We can see this also in carto images. In the middle of the screen, we see the good prematurity of the signals in both ablation catheters. And on the right side, we can see this Ozipka system. During follow-up, the patient was asymptomatic with a reduction of PVCs to 1%. Thank you for your attention.
So now Veronika Lekešová from Homolka will review cases from Homolka Hospital last year.
Homolka from Homolka.
Good morning. So I will start already with first case. PVI using single-shot pulse field ablation. It was 63-year-old man with symptomatic persistent atrial fibrillation. We performed pulse field ablation with Fermin catheter. We did PVI and box isolation, ended with electrical cardioversion. You can see here the both configuration of the Fermin catheter, basket and flower. After the procedure, we did remap with cartomap and we confirmed the isolation. The patient was discharged without antiarrhythmics and he kept in sinus rhythm till now. The second case was left atrial appendage closure using steerable sheath. It was 80 years old woman with asymptomatic permanent AFib. She was a high-risk patient for thrombotic events and bleeding. The occlusion of left atrial appendage was done with Amplatzer Amula 25 mm using skioscopy and intracardiac echography control as seen below. So she was discharged on dual antiplatelet therapy. Controls TOEs showed optimal position without thrombus or leak. Now she is on monotherapy with aspirin and she has no symptoms and no stroke. Case 3. Electrographic flow mapping and extrapulmonary vein source ablation. It was a 66-year-old man with symptomatic long-standing persistent atrial fibrillation. The procedure was performed with electrographic flow mapping using multipolar basket catheter and mapping system Ablacon that can detect potential AFib sources. We did PVI with pulse field energy, and then we proceeded to EGF mapping that identified two sources of AFib. Here we can see the source on ridge, and the second was on superior wall. We performed combined RFPF elimination of those AFib sources, and there were no AFib sources on the EGF remap as seen here. He had early AFib recurrence. We did electrical cardioversion, and now he's in sinus rhythm. Fourth case was power field ablation of AF combined with high energy RF. It was a 62-year-old man with symptomatic long-standing persistent atrial fibrillation. We performed combined PF and high-power short-duration RF ablation by Affera Sphere 9 catheter within Affera IDE trial. We did PVI, roof, mitral line, and CTI. Here you can see the catheter, and here is the ablation of CTI. So these are the results. The green points are where we use pulse field energy. The red points are where we did the RF ablation. Then we did remap and confirm isolation, the PV isolation, and conduction block on roof line. He was discharged on propafenone but had a early recurrence of 80. We did electrical cardioversion and he has sinus rhythm since then. Case number 5, guide wire mapping of Summit VT. It was a young 31-year-old woman with symptomatic frequent monomorphic PVCs, and she had no structural heart disease. We saw her a year before. We did cartomapping, RVOT, aortic cusps, LVOT, distal CS, but the ablation had only transient effect in all of the areas. So we suspected that the origin is in LV summit. Dr. Garcia showed us mapping technique of LV summit using a coronary sinus approach with multipolar MAPIT catheter with guide wire. But as you can see here, the activation was not quite optimal in anterior interventricular vein. So he went back to LVOT and the activation was excellent under left coronary cusps. After ablation, the PVCs disappear and the patient has no PVCs since ablation and has no symptoms. And the last case, single-shot pulse field ablation. It was 58-year-old man with extensive anterior scar after myocardial infarction. He underwent hybrid ventriculoplasty bioventrix in the past, and he has SICD implanted. He already had one cryo PVI for paroxysmal AFib. We presented this patient 2 years ago on this workshop. We did ischemic VT ablation. We used the pulse field ablation in apex because RF ablation was ineffective. He had no VT on amiodarone, but he had recurrence of AFib with inadequate shocks. So last year we did program ventricular stimulation. There was no VT inducible. And then we proceeded to left atrium FEMAP with Pentray catheter, and we found one gap on carina on a right superior pulmonary vein. We did re-isolation and posterior wall isolation. He was discharged on amiodarone. He kept sinus rip till February this year when he had recurrence of AFib, so we did electrical cardioversion. So that's all. Thank you very much.
Thank you very much for this overview, and now we start a first session of this workshop or this meeting, and this is dedicated to anatomy, and I have three distinguished speakers. Each of them will represent a different modality, how you can check for anatomy. And the first one is Joris Ector from Belgium. And as you know, you have already glasses for 3D visualization. And he will show you how you can fly through the heart and what you can see, all these anatomical structures important for electrophysiologists. So Joris, please. Thank you.
Okay, thank you very much, Josef. Thank you for the nice invitation and congratulations on the 25th anniversary of this beautiful workshop. It's an honor to be here and a pleasure. It's a great meeting over the years, and it's been a couple of years I've been here since COVID. But I think for many people that attend the meeting, it's great to see new technologies and new mapping systems. Many people look at cases and then decide which mapping system are we going for. And now we can also decide to go for a Steinway grand piano, 200,000 euros we heard, so we can choose between a piano or a mapping system. But we've seen many nice cases over the year, and I'm pleasure to give a talk on anatomy. I hope everyone received a 3D glass. Now for the first slides, it's not necessary. You can put them on, but it's not useful. The 3D slides will come in a moment. So just a short introduction. I am working in Leuven in Belgium, and over the years we've been working on image integration of 3D imaging modalities with fluoroscopy and later on with 3D mapping systems. And over the years we've developed some methods now for pulmonary vein isolation. What we routinely do is rotational angiography to reconstruct a 3D model of the left atrium. And now in our workflow, we integrate it in 3D mapping system, as is illustrated right here on the Carto system. We do the 3D rotational angiography by injecting contrast directly in the left atrium. we perform a rotation around the patient and we do a 3D reconstruction. The 3D model is then imported in the mapping system and we do ablation on the 3D model without creating a geometry with our catheter. So over the years, we reconstructed many models of anatomy in normal patients and in patients with cardiac pathology. And in the beginning, we did this with cardiac CT, now with 3D rotation angiography. And today, I will show you some of these models that were based on cardiac CT or based on rotation angiography. And for this presentation, I used a commercial available software called Amira to show the models. And we can show this in 3D. And for a large audience, I bring 3D glasses. So in a moment, you can use these to watch the anatomical models. So in the first model, we will look at general anatomy. I have to control this software live here on the system, so I hope everything goes without errors. I can rotate and slice the image. So let's have a look at general anatomy, and we can put on our glasses now. This is a cardiac data set based on cardiac CT. And in the beginning, you have to get used a little bit. When it starts moving, you will see that it's becoming a little bit more clear. So this is a cardiac data set showing the entire heart, and it's a CT-based data set. So it's, we are looking at a contrast-based image. So we are looking at the lumen of the heart, the endocardial surface. We are not actually looking at the myocardium. And I'll just have to take a moment to find my cursor. So here, this is actually an anteroposterior view of the heart with the right atrium in the back, the right ventricular apex in front, the outflow tract here, and you see the overcrossing of the aorta right there. And so I will now start moving the image a little bit, but I have to find the cursor. Okay, now I found it. So if we move the data set, we can go to a right anterior oblique view. This is 30 degrees right anterior oblique. And if we go further, we can rotate, and this is useful if you start ablating to get to know the fluoroscopic viewing angles. So now we are rotating and we are looking towards the apex. And this is a 60-degree LAO view. Here the apex is pointing towards us, and you see here in the middle the left anterior descending coronary artery and the left atrial appendage in the back. And when we move a little bit further, we go to the posterior atrium. Here you see a common ostium of the left pulmonary vein and then the right pulmonary veins. Now I will put the screen in motion. Just a moment. We go back to where the 30-degree RAO view. And this is a dynamic data set, so the heart should start beating right now. I'll have a moment to look towards it. Yeah, all right. So you see now the motion of the heart, and this is interesting in these kind of data sets that you can appreciate how the heart moves during ablation, because we're used to look at static data sets on mapping systems and we think it doesn't move, but it moves a lot. So we look and we turn around and we go towards the left atrium. You see the pronounced contractility in the ventricles. If you do ablation there, everything moves quite a lot. You see also the left atrial appendage. Here you see the coronary sinus branches we use for CRT implantation. But then, on the posterior wall of the left atrium, you see that the motion at the ostial level of the pulmonary veins is not that pronounced. This is one of the reasons that we can ablate there quite conveniently, put our catheters there, do an ablation, make good lesions. But if we look at other regions, like here in the left atrium, you see the mitral isthmus line, for example, the motion is a little bit different, and that's one of the reasons that we can struggle sometimes to get a transmural lesion right there. So I will turn the data set back towards RAO view, and then we will have a look inside the heart. So I will introduce a clipping plane and remove the lateral surface of the heart to look inside the right atrium and the right ventricle. So now we remove the lateral aspect. And here you can see and have a look inside. So here posteriorly, you see the crista terminalis with the trabeculations coming forward in the right atrium. Here is some artifacts because of the mixing of contrast agent with the blood during the acquisition of the CT. Here you can see nicely also the eustachian ridge between the inferior caval vein and the cavotricuspid isthmus. Here is the ostium of the coronary sinus, and this is the level of the tricuspid valve ring. So here, this is also a region we ablate commonly, the cavotricuspid isthmus. Then when we go towards the right ventricles, you see right here the outflow tract towards the pulmonary valve, and you see the close proximity with the aorta, so the aortic cusps and the posterior aspect of the right ventricular outflow tract. It's very closely related anatomically, and this is one of sometimes the more challenging structures to fully understand during ablation. Also, right here, you see the moderator band coming laterally, also a structure that can sometimes be the origin of ventricular ectopy. And you can imagine if you have to have stable contact on this structure that it can be quite challenging. So I will now put the clipping plane a little bit further to have a look inside the left heart. We go further down. And so we arrive in the left ventricle and the left atrium. You see here in the left atrium, pulmonary vein ostial regions are quite stable. They are anchored in the mediastinum, not that much motion. Here the patient is in sinus rhythm, and so there is a quite good contractility of the left atrial appendage. And you see also in the ventricle the trabeculations and the papillary muscles. And you see the motion and the environment that we move our catheter in is entirely different than in the smooth-walled atrium. And that's something you notice when you try to manipulate your catheter in a ventricle. You have to do it in another manner than in the atrium. And this is why when we're looking at 3D maps, it looks smooth, but it is not. It's moving and it's trabeculated. So I will remove this clipping plane. And I will rotate the image towards a left anterior oblique 1. And now I will clip off the anterior part. We remove the apex, and then we look towards the atria. You see here the coronary sinus ostium coming into the right atrium. This here is the tricuspid valve ring. I will come back and remove a little bit further. And then you see in the posterior part of the right atrium, the crista terminalis, right here. Here's the region of the sinus node at the epicardial level, the superior caval vein, and also the close relationship between the right superior pulmonary vein and the superior caval vein. Sometimes, if you map arrhythmias coming from this region, you think it's the SVC. It can also be the right superior pulmonary vein, which is very closely related. And this is the ostium of the right inferior pulmonary vein. So this was a general overview of anatomy. And now we will go towards a second model. And in this model, we focus more on the left heart and the left atrium. All right, this is a data set which is based on cardiac CT. So also we are looking at the lumen. And Josef picked as a title, "We Fly Through the Heart." So I had to do something like that to accommodate for him. So we will fly into the heart through the aorta now. So here you see the right coronary artery. Now we go towards the aortic root. and we stop for a moment, you see the cusps right here, and also the little triangular areas between the cusps where you have the myocardial sleeves that also often harbor the origin of ectopic beats between the right and the left coronary cusp. Here we see the anterior leaflet of the mitral valve segmented, and we will now fly further towards the left atrium. This might be a little bit, there is the ostium of the left main in the upper side, anterior leaflet of the mitral valve. Now it's a little bit blurry, but we go towards the left atrium, and we'll have a look at the pulmonary veins over there. You see the left superior and the left inferior, and now we look towards the ridge anteriorly of the left pulmonary veins. You see a very narrow ridge. So if we ablate, often we go inside and we try to make contact at the inside surface. It's very difficult in this case to ablate on this ridge, as you can see, but it's very depending on each patient with different anatomies. There is the ostium of the left atrial appendage. We will go inside, and you see the trabeculations inside the appendage. We go and fly back out. We look towards the ventricle, we go out, and this is an overview again of the left heart. So also cardiac CT-based data set. And in the next one, we will have a look at the right atrium. And this is based on a rotational angio that was performed during an ablation procedure in an experimental setup. Here we look at the right anterior oblique view of the right atrium. I marked the region of the sinus node in the golden color at the epicardial level, and we will have a look around. We go towards LAO view. You see, it's not easy to move the cursor, but I will try to point out. You see here is the right atrial appendage. We look inside, and this is a patient with a quite pronounced eustachian ridge. Here is the AV node, which I marked, and the region of the fast and the slow pathway that I marked with white lines. We go further down to have a look. We look towards the tricuspid annulus. We go inside. And you can also appreciate right there is the fossa ovalis, the region that we do transeptal puncture. And let's have a look inside the atrium. Now we look towards, this is a little bit difficult view. Now we look towards the cavo-tricuspid isthmus. We look down. And now we will go and have a look towards the AV nodal region, the triangle of Koch. We look from lateral side towards the septum. Just a moment, right there. I will stop it for a moment here. And so you see here, this is the ostium of the coronary sinus. This is the slow pathway region, compact AV node, fast pathway region, and this is actually the Koch's triangle with the base is the roof of the coronary sinus. And here is the tendon of Todaro, if you look in the anatomical books. And here is the septal aspect of the tricuspid ring. We will go a little bit further. And then we will move back out of the atrium, and I will just show some virtual ablation lesions on this model to point out a couple of points. All right, I will speed up a little bit, and we will go back towards this view. So if we look at this patient, there is a quite pronounced eustachian ridge, and this can make ablation sometimes more difficult. Also, when we make our ablation lines, we are not entirely sure at which aspect of the anatomy we are ablating. We don't have this model when we do an AF and a flutter ablation. So it might be that we ablate a little bit more septally. If you don't use intracardiac echo, you don't know. You ablate at 6 o'clock, but the rotation of the heart can be different. And you can see in this case, it would be quite difficult to make a good lesion at the septal site. Here at the eustachian ridge, you have to make a reverse loop to contact this region. It can be very difficult. And in these patients with a pronounced eustachian ridge, it can be more easy to make a more lateral isthmus line, like this one. At the lateral side, you can encounter sometimes more pouches, but you can see how much the anatomy can be different in just a matter of a couple of centimeters. I think intracardiac echo is a luxury to have, and Josef and his team use it a lot. In Belgium, we don't use it often, but these are the factors that can make a real difference. So here is also, I will mark where we often ablate for ablating AV nodal reentrant tachycardia. We come with our catheter towards the region before the coronary sinus ostium. We try not to go too high, and often we have the ablation, the sweet spot right here. Often we have to move our catheter a little bit to have nodal rhythm, but this is the slow pathway region where we do ablation of AV nodal reentrant tachycardia. Then I will quickly show one of the more difficult anatomical regions to really fully understand, and it's the outflow tracts, the close relationship, and the LV summit. I think time-wise we probably have to conclude then afterwards. I have many models. If people are interested, you can always come back later to me and we can have a look at specific items, but this is just to give an idea. In this data set, I indicated the cardiac muscle in the orange color, because in other data sets, you looked at the endocardial lumen, and you see here the myocardial muscle around the left atrium in the basal region in the outflow tract. If we go to a right anterior oblique view, it's this one. I will put a clipping plane. And you can also appreciate how close these myocardial sleeves in the coronary cusps are coming towards your posterior right ventricular outflow tract right there. You can have a look inside. And so the region between the cusps is also the region where often we get the origin of ventricular ectopy. Also interesting is to look at the region of the LV summit. And so this can be a difficult region. If you see in your distal coronary sinus, the coronary sinus is a gray structure here, earliest activation, then you know it might be difficult to do ablation. The LV summit is the origin of the ectopy. And you see how closely you are with the coronary arteries right there. And you can try to go there through the right ventricular outflow tract, which is quite close right here. Or you see here in the back the left coronary cusp of the aorta, also closely related. Often we have to try from different sides, or we have to try from the distal coronary sinus, but we are limited with the proximity of the proximal coronary artery, so a very challenging region. So with this, I will conclude the 3D part. I have other images for those interested of patients with tetralogy of Fallot, transposition of the great arteries. You can continue for a couple of hours, but I think for the sake of time and also to not to get too blurry with these 3D glasses, you have to get used to the normal world again. I will show you 2 more slides just in 2D. In Leuven, we are working on new ways to show these 3D structures, and so these glasses Yeah, it's good for large audiences. Now we are working, I have a PhD student, it's an engineer, who works with the Microsoft HoloLens. And we are trying to organize like anatomical sessions where you can see the heart in the patient or in the subject. So these markers, they serve as a registration to know how the torso of the patient is formed and where the heart should be. And then with the HoloLens, you can have a look at the heart inside the patient. This is basic anatomy, but just to know how the heart is oriented and where it is, for the beginning student, it can be useful. And then we are also looking at other applications that we can use maybe to guide procedures. And this is something we do with the Microsoft HoloLens, but also with more readily available technology with the smartphone. So we record a CT before a procedure, and we do registration. This is in a phantom still. And so we mark the anatomy. So to do a registration, we put markers on the patient. And in this way, we can register a 3D anatomy on the patient. And when the patient is on the table, the idea is that we can look through our device to see where the anatomy is. And this is done to, for example, guide the pathway of an epicardial puncture. And we can indicate the correct pathway that we would like to follow to do an epicardial puncture. And then you could look through the device to follow this pathway, and you have more information than just pointing at the left shoulder. So still basic work, not in patients, but maybe in the future I can come and knock on your doors to try this out in your centers where many VT ablations are performed. And with this, I want to thank everyone for your attention, and I'm looking forward to the next talks. Thank you.
Okay, so these talks are without any discussion. So if you want to discuss, just catch the speaker and discuss in the corridors. And the second speaker right now is Shivkumar. Okay, are you ready with this?
No.
So Shiv is one of the main leader of the EP in the California side, right? It's like West Coast in the US, and actually he will be speaking about anatomy for us, so anatomy for electrophysiologists. So, Shiv? Okay, that's fine. So I think it's always very important when we have the anatomical, perception, and actually we can just discuss in the, later on, what is the matter of pre-recorded imaging or just online imaging during our cases. And I think it's very important to recognize what we just saw during this Joris presentation, that some anatomies are very, very difficult, okay? And still, it stays difficult even despite all our new technologies, right?
U uppercase, capital U.
Okay.
C L B at.
Okay, so it's
It's not just at.
it's there. I put it there like
Okay.
manually. Vehicle.
Put this exclamation mark.
Okay, so it's in check. Now it should work.
Wow. Okay.
So
This is like a bank code here. Okay.
which one is it?
Prague, 2003,
2023. Yeah.
and the latest one, 2:49 a.m.
On the other hand, we can go with Fermin first.
18.3.
No?
The
Okay.
last one edited.
They are already open.
They finally opened. Sorry about that.
That's all. It's fine.
This one.
Okay.
You want to transfer
Yeah.
it?
It will be safer for the computer and the USB. It's super fast USB.
Now that we got the code to work. Click enable content. Click enable content.
Okay, enable.
And go to slideshow.
Yeah, it should work.
Nice.
Okay. Wunderbar. Okay, that's it. Is it okay?
Like this.
Okay, thank you all so much. Thank you so much for the invitation to the organizers. So here you go. This is, I'm specializing to show something about your city. Now it turns out that I should have put the picture that all of us, at least the team from the airport, from the hotel, we actually went to the statue today. And this was put in, for our team over here. Thank you so much. We actually had a pilgrimage to the site. So this is, again, the passion for our group, of course, has been shown in this slide. This is all the work done by my colleagues. I'm here giving the talks of the team. And what you see in this slide is two ends of what we do, complex interventions, and the other bookend of the slide is actually a light sheet image of nerves in the heart. So basic science and very complex interventions, these are the two worlds we live in. I was hoping to give you a quick overview of anatomy, starting with one or two words about history. One of the most beautiful anatomic collections in the entire world is, of course, was done by this gentleman, a cardiac surgeon, in private practice in Toledo, Ohio. We were very fortunate to be able to get his entire collection, which was sitting in the bottom of a library shelf in the Cleveland Clinic. It took about 8 years to digitize these original slides, and using the McAlpine technique, we were able to sort of recreate the way in which McAlpine showed anatomy to the world, which is to use pressure-perfused hearts. He was a cardiac surgeon, so he pressure-perfused these hearts so that you could look at anatomic specimens as it were in real life. Now, using this, and for the whole audience, if you could just use that QR code, you should be able to download this entire book, which is an open access book that's available free of cost for everyone in the world. This is the first in the series of 7 books that we are bringing out on cardiac anatomy, and I'll show you some highlights from the first volume. And the first volume is foundational, which has all the information about the heart, which subsequent volumes would be dealing with various aspects: interventional echocardiography, electrophysiology, structural heart. So let's actually dive into this. One of the big inspirations for this particular project actually has a link to European history, and for those of you interested, look up this term, and it's there in the book for you to look at. The Amarayat project, which is a multi-year effort to map the entire human anatomy. And we're starting with the heart, the 7 volumes in the heart, and after that, we're going to map the entire human body. So let's start off with the first aspect, and that is chest wall. In this meeting, you're going to see a lot of epicardial work, and the chest wall becomes very important for EPs on 2 extremes. One is where you place your ECG leads, which of course completely sets the stage for how a case gets done. That is the first point of interaction for an electrophysiologist, and of course, we're going to be doing a lot of cool things about getting into the heart. What is not well appreciated, and I think the very last image from the previous talk beautifully highlights this, that the position of the diaphragm within the chest is variable, so the thoraco-abdominal differences and where the chest leads are located has a huge impact on how we interpret the ECG. What is not well understood, and which is nicely shown in this particular slide, you can see, is the levels of V1, V2, and the fact that the subsequent precordial electrodes tend to go at a lower plane is something that we always have to remind ourselves. So this is a cross-section using McAlpine images showing you V1, V2, and subsequently the other chest electrodes. So the asymmetric location of the precordial leads is something that you have to remind yourself and place in the context of a given patient when you're operating on them. So there are so many aspects of anatomy, and I thought in the 20 minutes that I have, I thought I'll focus on aortic cusps, and roughly this has been set up in such a stage that it'll hopefully flow well with Fermin's next talk. This is an image that we spent a huge amount of time preparing at UCLA. I have a Berman catheter here in the left panel in the RV, and this is an RV injection with a levo face, with a catheter in the CS and the HIS. And on the right panel, what you see is a McAlpine dissection in the LAO. He did the attitudinal dissections of the heart, so progressive dissections were done. And we've overlaid the anatomic image and also the line diagram that was done by this. A very important advanced anatomical point that I'd like to sort of point to the group in this example would be to pay attention at the angle between the membranous and the muscular septae over here. So if you look carefully in this, the His catheter, both in RAO and LAO, you simply cannot get the His catheter and the other catheters in the same plane because the membranous and the muscular septae are at an angle. This is one of the most important anatomic features that I always like to highlight because the aorta always overrides. So when congenital cardiologists say that tetralogy of Fallot has aortic overriding, that's a complete misnomer. The aorta is equally committed to both ventricles. So that's a very important feature to keep in mind because if you appreciate that anatomic feature, you can prevent heart block during TAVRs. And I'll explain to you why. Because all these subtle features of anatomy becomes incredibly important for clinical practice. And on the left panel over here, we've also overlaid the images of the heart on this panel. And what you see over here where my arrow is pointing to is the inferior septal process of the LV. And that is going to be an important point I'm going to make in my talk, which is if you can understand the basal regions of the left ventricle, you could use that as an entire axis to understand cardiac anatomy. So what do I mean by that? Let's get to the next image. So an easy thing that we teach our med students is when you look at the iconography of any of the Egyptian statues, you see the crisscrossing of the hand. That's an easy way to remember that the RVOT is to the left of the LVOT. And of course, in this orientation, when you start looking at the heart and look at McAlpine dissections, you can progressively appreciate the complex relationship between the two roots. And this, of course, becomes extremely important for mapping VTs. Now, this is a section where McAlpine has actually bisected the heart so beautifully along the RVOT, and the axis that has been used is actually the aorta. So if you look carefully at this dissection, what you see over here is the beautiful relationship of the right ventricular musculature that overlies the aortic sinuses. Now, this becomes very, very important because when you look at the electrical mapping of the heart and each one of these electrical signals, you can actually relate to this anatomy. And this becomes very important, and hopefully, like what we did in 2019 conference, if I get a chance, occasionally I'll give you 1 or 2 slides that is contextual for the live cases that are being shown, because that's probably the easiest way to learn anatomy. Another beautiful way in which you can appreciate anatomy is shown over here, where McAlpine in this view has actually removed the RV free wall, and you look at the attachments, and now you can appreciate the beautiful relationship between the RV outflow tract over here and the aorta. So the aortic sinus, and you can see the musculature of the RVOT that's overlapping. So if you were to keep your hands together like this, it is the inner portion of your right arm that is resting over your left arm. That portion of the RV is the tricky area to map, and sometimes you may actually have to go from the IJ or move your catheter posteriorly to be able to record and get those signals. Next important concept. So if you were to do an exploded view of the ventricle, this is perhaps one of the most important concepts that was advanced by McAlpine, and that is when you look at the LV mass, and in this dissection, he's actually removed the RV, and the aortic and mitral valves as a single unit have been removed from this musculature. So this is the concept of the LV ostium. Now, when you remove the valves, and you can see in this example, you now are left with the muscular mass. And looking at it a little more closely, a simple way to remember this is to take your left hand and keep your index finger and thumb in a way you can, and if you don't touch your index finger and your left thumb, that would be the region, the shared annulus between the aortic and the mitral valves. So these 2 regions of the heart can be viewed as the superior and inferior septal processes of the ventricle. So when you look at the LV ostium, that is a quick way for you to remember. Now, we have confusing terms. The superior part of it, we call it summit, part of it which is, and the lower part, we call it the crux of the heart. But these terms, if you anatomically look at it, this is how it's organized in the human heart. And here is an image with and without the RV, but the valves have been removed. So you see this concept of the LV ostium and understanding these regions becomes very important. And it's not accidental. The LV summit, you can see that these two basal regions, the septal processes, is where the muscle actually folds on itself. And in some regions, the myocardium in a normal heart can be up to 18 millimeters thick. So it's not just 1 centimeter, it's almost twice the thickness, which is the reason why you may have to approach this using multiple approaches. So superior inferior septal processes. And this, I had set this up for Fermin Garcia, so when he shows you those images of ice, you can now see with and without the valves present. On the left panel with the valves, on the right panel without the valves, so you know what you're talking about and the regions we're dealing with. Now, the next aspect of this presentation is, I took the liberty to show you something interesting. Since people were handing out these slides, I thought I added these slides while the previous talk was going on. And I think if you get the light out now, you can appreciate the three-dimensionality of this place. These are anaglyphs that we have put in. So hopefully, are you able to appreciate that? I'm not sure if that shows up well. So here is, you can appreciate the three-dimensionality of the space and the crisscrossing of the two outflow tracts. And here is a progressive dissection on the same plane. Now you can actually see the mitral valves. So you can see the two leaflets of the mitral valve opening toward you and all the structures that was pointed out to you in a previous talk, except that you had to actually see partly a lumen image that was seen in the CT data set. But this is an actual pressure-perfused heart. And in the next image, we're also showing you the three-dimensionality in this case of mapping the RVOT, and you can see the flight path of the catheter. The IVC attaches to the posterior wall of the RA, trans-tricuspid, and you can see that you're just going past the commissure between the septal and the superior leaflets of the tricuspid valve to get just above the septomarginal band in the RV. Now you can come off the glasses, and you're going to use the glass only once more at the very end of the talk. So part of this conference, I was looking through the other talks that are coming up. I'd love to keep some of these images in your mind. Keep looking at the arteries and the veins to get into these structures. And these are all going to be areas where you're going to hear about alcohol injection, you're going to be hearing about wire mapping, and of course, you're going to be seeing a lot of areas from which we're going to be getting electrical signals of the two outflow tracts. And again, the concept that was already mentioned, all of this is in 3D, live, in motion. So whether it's fluoroscopy, X-rays, or you're using ice, which is probably the very best modality, it's nice to mentally register the location of all these structures so that we are always keeping in our mind what lies in front, what lies behind. And this is probably the single most important concept to keep in mind so that you anticipate and avoid complications. So this is epicardial, endocardial, transaortic, and coronary mapping for VTs. And I'll leave you with a little thought about the LV Summit, which is going to come a lot during this presentation at this meeting, and we already saw some from the previous years. These locations, especially when you can use the venous structures to get in, always keep in mind that you're dealing with two areas of the heart. Hopefully this will play. Thankfully it is. And here is a dual injection, both with a pigtail in the aorta and a Berman in the RVOT, to give you a three-dimensional appreciation of the structures that I'd shown you in a dissected heart. So all these areas here, we have used a small microcatheter in the anterior interventricular vein to map the the summit region. And again, these are the same areas where you can see the data from Houston, from Dr. Valderrabano's group, which has taught us to actually do occlusion venograms so that we get a full three-dimensional appreciation of that area for catheter ablation. And I will leave you with one other thought. Now there's going to be more and more technology, such as 4D ICE. Intracardiac echo is very exciting because it's fluoro-saving, and you can appreciate complex three-dimensional structures such as the LV summit or the crux of the heart. They are two sides of the same coin, all right? And the big lessons over here is, irrespective of the modality, anatomy is not going to change. The time we spend learning anatomy is well invested, because whether you're doing science or for patient care, this is going to be incredibly important. And newer modalities, here's an example of mapping near the aortomitral continuity region. Again, a little bit of a misnomer, because the aortomitral continuity actually does not have muscle, but the muscle close to those regions, this is pretty much how your catheter profiles are going to be looking, and how you can start understanding images once you keep that in electroanatomic context. So I'll leave you with the last two slides, which is, no matter what approach you use for the superior and inferior septal process, I'm keeping this as a theme for this year's talk, is you can access it endocardially, epicardially, transvenously, through the arterial system, and sometimes you may even have to go intramyocardial by using CTO-type systems, where that you can actually insert a wire into the myocardium for intramyocardial mapping. So these are all the ways in which you can approach these structures, and it's a tough area of the heart. And we're going to be hearing a lot in this meeting about how we tackle with all these problems of epicardial fat, how do you get to these structures. So I'll probably leave it here and switch to the very last slide, which I wanted to show to you with a 3D approach, and that is, we'll show some of the AB junction slides during the conference if we get a chance. I have a lot of information on the node and so forth, and we can show this during the meeting, but I'll leave you with the very last slide, which is, this is the 150th birth anniversary of Dr. Tawara. So for those of you interested later, we can talk offline about the location of the conduction system. And the very last slide I wanted to leave with you was, of course, neuroanatomy of the heart. And I should really salute the group here in Prague, because you've done such remarkable work in cardioneural ablation. And your very last slide, if you wear your glasses, you'll be able to appreciate the three-dimensional anatomy of a structure that we love, which is nerves of the heart. So here are the structures we target, all the way from the stellates to the plexuses of the heart, the superficial and the deep cardiac plexuses, all of which are ablation targets. So, and I think that's exactly on time. I'll stop here and thank all of you for this great opportunity.
Okay, so Shiv, thank you very much. Okay, can I hear? Okay, perfect. Okay, thank you very much. And actually, you introduce Fermin Garcia from Philly, and he will be again spending some time to connect his computer. So in the meantime, actually, I really want to stress, what would you prefer in our clinical practice? To get pre-procedure imaging or this online imaging?
Yeah, it's a very good question.
You need to be, well, okay. Fermin, let me finish this.
I can give you my perspective on this, because we travel all over the world. We're very spoiled in America. We started with the insurance companies, but we can get MRIs and CTs. But perhaps I was talking to Fermin, hopefully he'll agree. If you're allowed to pick one modality for imaging, I would pick ICE. I would pretty much say that, if you had good electrical recording and ICE, you perhaps someday could even do a procedure without fluoroscopy. Okay. So that's my bias.
I'm happy to have the same bias as you have.
But hopefully 4D, right? Hopefully 4D. Okay.
No,
okay.
you
No, that's
don't
fine.
need
Hopefully
4D.
4D. Okay. Fermin, thank
any
you.
eyes.
Okay. Sir, podium, sirs.
Thank you, sir. Thank you, Josef, Peter, everybody in this meeting for having me here. It's for me an honor to present this because over the years this has been presented by Josef. Last year he did a fantastic job, and I don't know if I can fill those shoes, but I'll give it a try. I presume when we talk about online in the EP lab, we're talking about the only online that really gives you anatomical, although I will vary it, because it's not fluoroscopy. It's, in my opinion, intracardiac echo. And the real term that I would like to use is real-time imaging. It's while you're doing the case. And real-time imaging to define anatomical characteristics for a patient. And every patient is different. So the anatomy for one patient is not the same that for another patient. So if you think you know something, you need to know something for each exclusive patient. And this real anatomy helps you with catheter location, contact, perhaps lesion formation. It's something we have everywhere. If you can't sometimes integrate with mapping systems, if you're using some mapping system with integration, we can help you also define substrate and scar. And if you don't care about anything I'm going to say in the next 25 minutes, at least you should know that you're always going to be at risk of a complication. It doesn't matter how many procedures you do, and ICE will help you prevent a catastrophic problem. So this seems like, I don't know if I can do this. I'll try. Because in my way here, I wanted to do 25 anatomical facts for each year of the conference, but I don't think I'm going to get there, so I'll try 20, and if not, I'll stop. I'm going to start with the simple thing, which is the most common thing that we all know. It's cavo-tricuspid isthmus. This is the anatomy, and what I'm going to try to do is correlate some of the anatomy, like Shift showed, with a nice picture. This is your target, the isthmus of the left atrium. And here, on the eyes picture, I'm going to try to show you what you can see. This is the Eustachian ridge correlated to number 1. This is the pectinate muscles correlates to number 2. And this is the tricuspid valve correlates to number 3. So you have a length, you have the obstacles, you have thickness, you have a prominent Eustachian ridge, and this is how we define anatomy with echo. And we will apply this to every single aspect that I'm going to be talking about. Because by knowing this, you know how to do the ablation, you know if the patient is a challenging patient or not. This is an example here of a very prominent Eustachian ridge and how we learn to turn the catheter sideways to ablate this, because you simply cannot ablate it in the common way, which is pushing it down. And here, I'll show you the fluoroscopy of this, because you can see here, if you compare to this, yes, it looks like you have a loop, but you don't understand what's here, because you cannot see these tissues with fluoroscopy. And that's the whole point of this talk. I'm going to then show you in the right atrium. This is very important because this was shown on the first image. So with intracardiac echo, you can easily look at the superior vena cava, this region right here from McAlpine, and the so-called arcuate ridge, which is a septal extension of the crista terminalis and the right atrium. So if you do anteroflexion, you see up, this is the SVC. This would be the intraatrial septum and the superior pulmonary vein. And you can see now what I've been doing lately, which is use eyes from the region of interest. Now, this is an image of the SVC with eyes in the right atrium. This is an image of the SVC with eyes on the left atrium. Here you have the pulmonary artery, the intraatrial septum. You can look at the thickness. Every patient is different. You can have a thin septum or a very thick septum. This is the SVC and your ridge of the crista terminalis here. So if you were to have to map this area, which is floating, how are you going to do it? Well, you cannot do it precisely with fluoroscopy, but you can do it precisely with intracardiac echo. And you can see here, if you equivalent, this image of McAlpine is exactly the same image of eyes. So that's why eyes doesn't lie. You can see here the SVC, the ridge, and all the trabeculations, very similar to what's happening here. It's exactly the same. So you start thinking in your mind, what are you going to do? like a blood cell, I'm going to move to the next chamber, which should be the right ventricle. And there's nothing more useful than intracardiac echo for intracavitary structures. This is an image, again, from a calpine of the moderator band and the pectinate muscles. And this is how it looks in intracardiac echo. You can see here, you have a lot of moving structures, okay, in this area. Now, this is a patient that comes for ablation. If you were to have to target these structures here, you have to have contact. And this is very difficult, and the patient is breathing, and the heart is moving, and is. So if you can identify, you can tailor ablation therapies. I'll show you here the fluoroscopy of this catheter location. You can see here, okay, that the sheath is pointing up and the catheter is pointing down. You would never think that this is on the moderator band, but you're tailoring the shape. You're parallel to the RV free wall. You're putting your catheter on this aspect of the moderator band, and you're pulling it back to improve your contact. Because right there, you're going to have an early signal for a PVC on this patient coming from there, and you will never get 100% with PASO, but you get 99%, which is pretty good, okay? Because sometimes not perfect, but it's very good for PASO or for pace mapping. But the key is contact, contact, contact. If you cannot have contact, you cannot ablate. So you have to identify your area of interest, and then you have to have contact. Nothing more useful than the tricuspid mitral annulus to know what you're doing. In the past, we used to put that catheter clock and try to fight. The whole point of this is you don't fight anatomy. You work with anatomy. So if you have to burn this area right here, call it a PVC, an accessory pathway. Same thing for accessory pathways. Same thing for endocardial, RV cardiomyopathy VT. It doesn't matter what disease it is. You have to burn around the structures of the valve. You have to have good contact. You don't push the tricuspid valve. You get behind it and you work with it. Here the catheter has no contact. Here the catheter's open up and has contact. And this is how it looks. You use your sheath to help you create a space so you can put that catheter there. This is direct visualization of this with fluoroscopy. You cannot tell where the tricuspid valve is. And it also helps you because once you get there, you have good contact. Again, I'm going to show you multiple examples to see that I'm not lying. This is EGMs around that area. This is the His. A lot of these things were called parahesian pathways. They were not parahesian pathways. They were just mapped wrong. And how you know this? Because also ICE is useful to tell you where you are and where you're not. If you have a cut in which you see the aortic valve, just like Shift show you, this is the His region. You are on top of the His. But if you then counterclock a little bit, and now you don't have the aortic cuffs, and you don't have the pulmonary artery, but you can identify right here the fat pad of the right coronary artery. That means you have moved off the septum, and that means you will never cause heart block, and that's how you tell that you're not on top of the His. So it's a three-dimensional tool that helps you, all these things. RV free wall, scary, because we think we're going to perforate. But the truth is, we don't get there, and that's a lot of the cases we went to the epi, and we even fell on the epi because we didn't recognize this. This is a patient with VT in the setting of RV cardiomyopathy. This is the cut with cartosound to show you the free wall of the RV. Look at this endocardial aneurysm. You cannot see this with fluoroscopy. You're scared to push on the map. You never reconstructed this, but you can see it here. And if you go epi, this is full of fat, and this is a right atrial appendage, okay? However, if you see this under direct visualization, you can ablate it, and you can put the tip of your catheter there with some manipulation, improve outcome, and you effectively map things. RVOT, nothing more useful than that. Two views to understand this anatomical region that Shifts described. A long axis view from the atrium, okay, and a short axis view from the RV. I put here how to obtain it. Right atrium, looking down, cross the tricuspid valve, look up, RV afflotract. Okay? This is long axis view. This is the right coronary cusp. This is the pulmonary artery. This catheter tip is touching the posterior aspect of the right ventricular afflotract, the so-called infundibulum, and the opposite structure is the right coronary artery. So this is a concept we dealt for years now, which is, who is my neighbor? If you are ablating the RV affluent tract posteriorly, you ask yourself, who is your neighbor? You look at intracardiac echo, your neighbor is the right coronary cause. So you have to map the right coronary cause, you have to map the posterior RVOT. Okay? Here in the short axis view, you see here the right coronary cause and the pulmonic valve. All this is below the pulmonic valve because that's the RV affluent tract. Once you cross the pulmonic valve, it's called the pulmonary artery. And that's very clearly visualized with intracardiac echo. You cannot see that with fluoroscopy. This is the fluoroscopy image for this intracardiac echo. You can see here exactly where the tip is. Here, you are guessing where the tip is, but you don't know for sure. And that is a simple ablation. RV affluent tract, PVC, the most common PVC, which I don't see anymore, it's right here. And you can see very clearly here, RV affluent tract, left atrial appendage, RV affluent tract, left atrial appendage. This anatomical, this eyes picture clearly delineates that. And in between is the LAD. So you have to be careful because as I will show you in a second, this could be a problem. Coronary cusp, this is the only image, because it takes me a lot of work to do this, that I did not flip over. This is pen way. So the marker, it's on the other side. So I apologize for that. But this is how you obtain that image. RV affluent tract, you look up, and now you have this. And what I'm trying to show here, this is the RVOT. This is the pulmonary artery. Left atrium, non-coronary cusp, left coronary cusp, right coronary cusp, and in between this, right-left junction. So the right-left junction is right opposite to this aspect on the septal leaflet of the pulmonic valve, just above the RVOT. Becomes very useful for LV summit, and we'll discuss that in another talk. But if you want to map the RCC, you can put the catheter right here with intracardiac echo. If you want to map the LCC, you can put the catheter with intracardiac echo. And in between the RCC and the RVOT is the most septal region of the septum of the LV ostium. And that could be 0.5 centimeter, or it could be 1.5 centimeter. And when you identify this with intracardiac echo, you decide where are you going to burn it from and what power are you going to use. And sometimes you have to sandwich from both sides. So again, the utility of seeing things. And if you want to get fancy at mapping, you know where to put your catheter, because sometimes PVCs are tricky. And I'm showing you here that in one view, you can record the EGMs for every single one of these components. And if you were to have a mapping system, and this of course I did in Photoshop, but if you were to have a mapping system to delineate them, you would say your best point is the R left junction. And the second best point was right here, because it's opposite on the other side, in the pulmonary artery. But if I were to choose where to ablate, I would rather ablate on the right-left junction because, in my opinion, it's safer than ablated in the pulmonary artery, and I will show you why. And then, on intracardiac echo, I can see the tip of my catheter in perfect position between the right and left junction, and I know I have a good vector orientation and 14 grams of force, which is very good, and this is how it looks in fluoroscopy. You have 0 details. You're just guessing where you are. It's not the same. Pulmonary artery, why is it useful? Well, it's useful because you don't want to get there unless you need to. And the reason you don't want to get there unless you need to is because if you using the catheter the wrong way, behind the pulmonary artery is the proximal segment of the left anterior descending, or the left main. And if you go very high with the catheter going forward and the patient takes a deep breath during ablation, your catheter will go straight to here. And that structure right there is the LAD, okay? So don't burn there because it could be a problem. And you can see that if you're going to burn there, you have to stay below the cusp. And that's what's important to do it. However, I recognize nowadays that we might have to burn from the most septal portion of the pulmonary artery because we have the extensions there, and that's right anatomically on top of the LV summit. So if you're going to do it, this is the curve you should be doing. You curve your catheter like this, and you put the tip right here, because then you pull it back and you hook it, and there's no way that that's going to bounce forward and you will not damage the LAD, okay? So keep that in mind. And this is very beautiful because here I have, let me just replay that. This is a video following down the LAD from the top to the bottom. Because it's important that when you're going to burn in the anterior RVOT, which is believed to be such a safe area, the distance from the anterior RVOT to the LAD will determine if you are at risk of this. If you are very close, sorry. If you are very close, maybe it's just this slide. I think it's just a slide, I apologize. But if you're very close, you could damage the LAD right there. So this distance is very important. It's just that slide. And then the pulmonary artery is important because I love it. I don't do TEs anymore. You rule out a clot on every AFib ablation, and you have a better view of the left atrial appendage that TE will never give you in your life. So from the PA, you look down, you're right on top of the, you can even look at the most tip portion, okay? And then you can say, oh, my patient has a smoke, okay, no problem. Oh, my patient has a clot, I'm not doing anything. So there's no better way to clear a left atrial appendage than intracardiac echo in the pulmonary artery. So the pulmonary artery, it's helpful. I'm going to move to the atrium, and I'm going to show you the veins. Start with the left veins. This is histology and macroscopic anatomy of the left pulmonary veins. You're supposed to be burning somewhere in here, and I love what you show about the new technologies for eyes, because sometimes I feel like we're going to get to a point that we don't even need to know anatomy. We just have so good tools that you can do whatever you want, and I don't think that's the case. It'll never be. But this is beautiful. This is 3 different patients. Again, eyes inside of the left atrium, to show you the left pulmonary vein and the ridge between the left pulmonary vein and the left atrial appendage. In the back, in 2 or 3 patients here, the 3 of them, you can see the esophagus. You can see the thickness of the posterior wall, the relationship with the esophagus, and you can see 3 different pulmonary veins, all different. In fact, all the AFibs I do this, there's not a single patient that has the same pulmonary vein than the other one. So I like what you showed at the beginning, Josef, where you show how to place these new catheters with intracardiac echo. I think that would be useful, but this is important because when you're ablating things, you want to see what you're doing. And this is simple ablation. This is what we have in the United States. This is just an ablation catheter that depends on contact and force to create a lesion. But if I can see it, I know what I'm doing, and I know that I'm burning this. And you have pretty good outcomes when you use these tools with detailed anatomical correlation. You also can prevent problems because you have exactly know where the esophagus is, and you know the thickness to the esophagus. So this is real anatomy in the EP lab. I love this because I think this to me open up the isthmus. This is the anatomy of the mitral isthmus, and I'll deconstruct it for you. The most distal portion is the LV, the mitral valve, the space between the mitral valve and the left inferior pulmonary vein. Then you have the great cardiac vein and the circumflex surrounded by the fat pad. So this could be short or long. It could be concave, it could be thick, it could be thin, it could move, it could stay. And if you, in your mind, thought that mitral isthmus is the same on everyone, you're absolutely wrong. And this is how I see it. This is the mitral isthmus, okay? You have the left inferior pulmonary vein, you have the mitral valve, you got the great cardiac vein, I can tell you the thickness. This is an example of alcohol. When you inject alcohol, you're affecting the portion behind the great cardiac vein. And then you will always have to ablate from there to the mitral valve. And then sometimes even you will have to ablate from the great cardiac vein because there is a segment that alcohol did not include because it's anterior to that. If you understand this, you'll get blocked on the mitral line 100% of the time. Now, I'm talking about RF. Maybe even with PFA will be better. But what you need to understand is not all mitral isthmus are made the same. This is a big pulmonary vein with a concave short mitral isthmus, in which the circumflex artery, it's subendocardial, and it's on the other side of the great cardiac vein. So no surprise that even the new technologies, if you're applying a lesion here and the circ or the distal portion of a branch of the marginal, it's here, you will get a spasm because it's subendocardial. Here's an example in which it's long, but the RCA is on the other side. And this is an example where, again, look at the RCA. It's right there. I'm sorry, the circumflex is right there. So all these are different. Every patient is different. And if you understand this, when your patient is on the table, you tailor the therapy for the patient on the table. This is anatomical relationships now of the right pulmonary veins. I love this. This is ice in the left atrium, and I'm going to just clock it, okay? So this is the aorta, intraatrial septum. This, as I move, is the pulmonary artery, the SVC here. I move more, my catheter is in the right superior pulmonary vein. And I move more, this is the posterior wall, the carotid region. I move more, and I open the right inferior pulmonary vein. So if I want to tailor the therapy for this patient, I will stop the ice at every segment that I'm going to ablate, and I know exactly thickness, location, and everything I need to know. And that doesn't come more powerful than the posterior wall. This is how you look at the right pulmonary veins. This is the posterior wall and the right inferior pulmonary vein. That's the descending aorta. Look at all these patients, different sizes of right inferior pulmonary veins, but more importantly, different sizes of posterior wall. So we don't fail in the posterior wall because it's bad. We fail because every patient posterior wall is different. If you have a posterior wall that is almost a centimeter, it cannot have the same power as something that is 3 millimeters. Have you ever thought when you're applying in the posterior wall that you are going to consider the actual thickness of the tissue? I don't think so, because you have not been looking. I haven't been looking until I started doing this. And then I decide how much I'm going to do and what is the proximity to the esophagus. So not all posterior walls are the same, and you have to tailor. I like this view because we burn in the roof of the left atrium like nothing's going to happen. Well, when you look at this image from McAlpine and I show you this ice image, it's kind of scary, actually. This is the left atrial appendage. This is the left atrial appendage. This is the left coronary cusp. This is the left coronary cusp. This is the left main, guys. This is the left main. You want to isolate the left atrial appendage and do a nice circle around the left atrial appendage because nothing's going to happen. Well, think about it twice, because you're sitting right here on top of the circ and the proximal LAD sometimes. So all these are very important anatomical facts that you have to consider. When you move to the left ventricle, I have no other way of explaining that you cannot do papillary muscle VT if you don't have intracardiac echo. It's the only way. Now, what I'm going to show you here is very interesting because this is how I was used to use echo for years. Eyes from the right ventricle. Well, now I use echo inside of the chamber of interest. So if I want to image the papillary muscles, instead of looking at the posterior medial pap muscle that looks like it's here, I look at the posterior medial pap muscle from inside of the left ventricle. On the same patient, 5 minutes later, not only can I see a beautiful pap muscle, but this patient survived sudden death, has a scar at the base of the left ventricle that I could not see that well here. So it opens a new scheme if you image in this chamber of interest. Because when you're doing that, in papillary muscle, for example, you really can direct where you're going. This is the patient, the tip of the pap look a little white, maybe there's some abnormalities there. Well, you put your catheter there, you have a late potential, and during that PVC, that late potential becomes early, and this is a continuous recording. And if you're going to ablate it and you're going to use high power, you would like to see what's happening. You like to have your eyes in the catheter, so when this happens, you know you apply that lesion in the right place and not in the wrong place. Because also, we want to prevent complications. I'm going to skip that, that was the same. Now, so we tend to fail. Why do we fail? Because we don't know if it's the bad technology, etc. Well, maybe we fail because we're not seeing things right. This is a patient with a PVC that looked like a fascicular PVC, have failed 3 procedures, and I was asked to do and help, and I couldn't figure out. But when we put ice in the left ventricle, one thing that became apparent that I couldn't see with ice from the right ventricle is there was a band connecting here to the distal portion of the septum. And I said to myself, well, this PVC looks like it's exiting towards the distal portion of the septum. Perhaps this little band of tissue right here has something to do with this arrhythmia, and let's go and map that band. And right there, you saw a potential that became super early on top of that band. It was very difficult to have contact, but at least we identified what was happening. This is the inferoseptal process that Chief talked about. Love this image. This is the RV, the LV and the right atrium, the LV and the right ventricle, and what you need to know that the so-called crux of the heart, doesn't, in my opinion, is a good term, but basically the RV inserts below the mitral valve. This, you have to put it in your head. They're not at the same level, and that allows you to the right atrium to have access to the left ventricle without going epicardial. And that's AV-NRT on the right side, and that's VT on the left side. And that is this image. And that is this image. This is RA to LV. This is right atrium, left ventricle, right ventricle, tricuspid valve, mitral valve. There is a step up. I'm using this because it's the most exaggerated one I've ever found in my life, and I think it makes the point very clearly. From the right atrium, you enter the left ventricle. We ablate AV-NRT, we ablate PVCs from the right atrium into the LV, and if you have a mechanical aortic and mitral valve, you can enter the left ventricle through this space. Okay? Transatrial to ventricular puncture. And PVCs can come from there. And we look at this, and we were lucky to understand ice and fail in the left side and ablate these PVCs from the right atrium. This is the right atrium, and we're ablating from the right atrium into this area of the left ventricle. And that's how the catheter position looks. But sometimes you get confused, and this is beautiful, right? How do you define a his on the left side? Well, I found ice on the left ventricle. I look at the LV outflow tract right here. You see the ice cut on the left ventricle at the level of the mitral valve. Looking up, I put my catheter in the membranous septum, not in the muscular septum. Membranous septum, muscular septum, RV, tricuspid valve, and you have a beautiful his. Now, I know that I don't want to go there, but I know I want to map my PVC. Okay? That looks like this, and it was so-called parahesian PVC, but you find the earliest area of activation here. Now, this ice image has the beginning of the pap muscle at the bottom. You can see right here the ice cut. So if I'm a little bit above there without going here, I can get rid of the PVC without causing heart block. So this is the whole way of seeing things in a different aspect. LV septum, somebody said today the heart is moving. No question about it. If you try to ablate the LV septum, it's one of the most difficult things to do. This is 2 different patients with LV septum. I am imaging all my VT patients for LV from the left ventricle. Look at this LV septum, look at this. Which one is going to be more difficult to ablate? Clearly this one, because it's very thick. Both patients have intramural VT, both septum have septal VT. This it might be a little easier because it's thinner than this one. But how much movement there is? How can you get a catheter here to be stable? So the reason we're failing here is because this is what happens. You're trying to ablate the LV, and the catheter is slipping back and forth, and you never get a lesion. Never get a lesion. The only way you're going to get a lesion is if you see this. So this could improve outcome if we use it the right way, because now you have a catheter in the septum that is not moving, and you are creating a lesion. And then my neighbor is the right ventricle, so if I want to finish the job and have a transmural lesion, I must go opposite to that, and I must ablate opposite to that area to get a lesion. And this is a labor of love. This takes a lot of work and a lot of dedication to get that catheter there and do that. LV substrate, I'll go fast here because it's very simple. Scar looks dense, white, and hyperechoic, but also has wall motion abnormality and thinning. So you have 3 things. White is thin, and it doesn't move. It's a scar. It's basics for echo. So when you bring a patient to the lab for a VT ablation and you see this, this wall is not moving as good as the rest of the hair and looks white, and you have VT, and you suspect this, and you go to the epi, this is the ice cut in cartosound at the level of this area, and when you do the multipolar mapping, you have your substrate for VT. So this is a very powerful tool. Intracardiac echo combined with mapping. It's a very powerful tool to define substrate in the EP lab, real time, online, and it doesn't fail. Even on the most difficult cases in which the endo and the epi are normal, but in intracardiac echo, you can clearly see that there's wall motion abnormality and a hyperechoic region, and that must be intramural. So this is a classic example of protected scar inside of the muscle. Normal endo, normal epi, very hard case because it's very difficult to map. And you have sometimes to burn purple areas because in the endo, you're trying to reach this area of intramural scar. Very hard, very difficult. Now, if people thought for years, I don't use ice because I'm really good at transeptal puncture, and that's the only thing ice can do well. I just show you that the least thing is transeptal puncture. But if you're going to use it for this, it's useful because you can design where you're going to do your transeptal. And in difficult cases, in difficult cases like a ASD closure device, you can select where you're going to puncture. In a patient with amyloid, you can select where you're going to puncture because you want to go to the thinnest portion. But what if I tell you that every time you go in a transeptal, you must look at your sheath because most clots in the left atrium you bring from the right side. Look at this. This is a patient we're going transeptal. ACT is 350 in our lab every time before we are crossed. I aspirated from there. This is another example. Look at the sheath. Have you ever thought about looking at this before you go transeptal? So forget about going transeptal. It's prevented complications. And of course, prevented systemic complications. I would not go here retrograde. This is a patient with severe calcification and mobile clot in the ascending aorta. This is a patient with an apical aneurysm and an LV clot. This is a patient with a scar and a calcified LV clot. Don't map it, don't burn around here, don't put a multipolar catheter here or you're going to chafe this. So you can prevent systemic embolism by close attention to all of this. And finally, if the patient is hypotensive and you don't know what's happening, you look at eyes. Either the heart is not moving, or for some reason, the patient, like in this case, hypertrophic cardiomyopathy, has outflow tract obstruction, or the most common reason, there's an effusion. And if you pick it up, you prepare for your puncture, you take care of it, and nothing's going to happen. I think overall, ICE is the most powerful, real, on-time tool in the EP lab. And I will stop here, and this is the picture that Chief was talking about. We talked this morning, and I put it for you. I put it here so you can show it, okay? Thank you very much.
Well, thank you very much, Fermin. It was exactly what I intended to show and how to demonstrate in such a vivid way how you do. And I believe that you persuaded everybody that ICE is really important. So thanks very much. Because we have some small delay, so we will reconvene in half an hour instead of 12:30, 12:45, and I believe that we will manage this time difference in the afternoon.